With the DOACs, you could look at some of their advantages as being a more rapid onset of effect, and if you do get a major bleeding complication because of their shorter half-lives, the effect on that bleed will be usually shorter. Some of their disadvantages, they do not require routine monitoring for the therapeutic effect, which many people consider an advantage, but some would consider that a disadvantage if you wanted to do a procedure and you don't really know how anticoagulated that patient is because you don't have a readily available test for that. The availability of the DOACs has changed our thought process as we see a new patient, let's say with atrial fibrillation. You now have several options since there are 4 DOACs plus warfarin, so you have to individualize that decision-making process for each individual patient and in fact incorporate the patient's wishes in many cases into which of those agents you might select for therapy. It was interesting when the Graham study came out recently to look at how that study was conducted, the kinds of patients that it represented, and what the results were. The Graham study, Graham works for the FDA, so this was an FDA-generated study looking at a Medicare population, so therefore it does represent that common AFib patient, 65 years or older. And they looked at 119,000 patients who were on either Medicare Part A, Part B, or Part D. So therefore they had medical claims as well as prescription claims data to assess the effects of drug therapy on outcomes. It was nice to see that this trial was actually conducted by the FDA because I think what that represents, and if you're familiar with how the FDA does drug surveillance after post-marketing drug surveillance, is that they typically in the past have relied on spontaneous reports that just come in from prescribers or other healthcare providers. This is a different way for the FDA to look at post-marketing performance of a drug in the real-world environment. And so it's important that the FDA is the one who sort of initiated this as part of their role in looking at post-marketing drug surveillance. The Graham study looked at the outcome associated with the 2 usual doses, rivaroxaban 20 milligrams a day and dabigatran 150 milligrams a day, assessing the rates of thromboembolic stroke, the rates of intracranial hemorrhage, the rates of non-cranial major bleeds, including GI bleeds, and then total mortality. And in this observational study, what they found was that compared to dabigatran, rivaroxaban was associated with a non-significant reduction in the rates of thromboembolic stroke, but significant increases in the rates of both intracranial hemorrhage and non-intracranial major bleeds, including an increased rate of GI bleeds. And there was a non-significant increase in mortality associated with rivaroxaban as well. The clinical importance of this study is that in the absence of proactive head-to-head clinical trials, we're going to need to rely on observational studies like the FDA did to get an assessment of how these drugs compare to each other in the real-world environment. And using the Medicare data, I think this study represents how these drugs are performing relative to each other in a real-world environment. One of the advantages of DOACs is that they have a simplified dosing strategy relative to warfarin. There's typically a usual dose, like the doses we talked about in the Graham trial. The only major need for a dose reduction or alteration in that standard dose would be based on either renal function, because all the drugs have varying degrees of renal elimination as part of their elimination process, or other patient-specific factors depending on which of the DOACs that we're talking about. Otherwise, a pretty standard dosing applies to the majority of patients. For managing their side effects, it's almost always the only side effect you're ever going to see is if these drugs cause a bleed. So the side effect management is typically just related to whatever bleeding complication they may occur, whether that's a minor bleed or a major bleed.